Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health where we take your questions about quality programs and the transition to value-based care. My name is Hadley Taylor, a MIPS quality consultant. I'll be hosting this episode along with Dr. Dan Mingle, founder and executive chairman of Mingle Health. Good morning, Dr. Mingle.
Good morning, Hadley, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle. I'm here to answer your questions to the best of my ability. A couple interesting questions today. I'm getting caught up with some issues I've been neglecting. Karen, you've been quite patient with a bunch of questions about ACOs, and I've got an HCC question and APP question that are timely to answer today as well. So let's get started, Hadley.
Okay. Our first question is from Lori. Lori asks, is there any technology or even lists to capture the top HCC risks?
Boy, great question, Lori. You sent me on a scavenger hunt on the internet to answer that one. Unfortunately, I've got little to show for it. For those of you unfamiliar with HCC codes, let me explain what they are. Multivariate statistical analysis of Medicare claims, now that's a mouthful, has shown that there's a correlation between certain diagnosis codes or combinations of diagnosis codes with higher healthcare costs. It stands to reason that patients with renal failure, complicated or fragile diabetes, certain cancers, brittle congestive heart failure cost more for annual health care than other less complicated patients. Medicare has assigned scores to each of these codes or code combinations intended to adjust charges and payment profiles for complexity, with a theory being that practices that take care of more complex patients end up having patients that cost more and consume more annual Medicare, more of the annual Medicare budget. So this is an attempt to adjust it and get an even handling of cases across the nation. It was introduced to adjust payments in Medicare Advantage plans starting in 2004. In more recent years, it's become apparent that cost and quality measures required risk standardization. So Medicare applied it to their value-based payment programs. Annually, Medicare updates the analysis, including codes and risks. For the model, over 10,500 ICD-10 codes are mapped to 86 HCC codes. And each HCC code is given a numeric cost score. Some of those codes are additive, some are exclusive. So if you have this code, it overwhelms the rest, and it's the one that drives costs. And that hierarchical staging of the codes is why it's called hierarchical conditions codes. Medicare used to publish the mapping and the scoring hierarchy in text and tables that could be understood by any determined reader. But today, mapping logic of the ICD-10 codes to the HCC codes is published in a spreadsheet format with the HCC naming and scoring hierarchy hidden in what they call model software. It's designed to be installed and run on SAS or SAS compatible technical environments. So a little difficult for the casual reader to understand. They update every year the ICD to HCC mapping and the risk-related relative scoring of each code and the application of scores to specific patients. The practical implication of this annual cycle to providers is that HCC-scored ICD-10 codes have to be used by the provider in a service year for that code to be applied to the patient. So it's not enough to diagnose it in the patient wants, and it's diagnosis on a claims form that matters, not diagnosing it in an EHR. You can find articles and presentations here and there that illuminate some of the common errors, but I haven't found any in-depth listings or articles describing the whole system. And I think for any in-depth or comprehensive analysis, you're likely to require vendor assistance. I've done some coding, I've done some analyses of these systems, and I found two analyses to be helpful. One is a missing code analysis. And in a missing code analysis, I look for HCC mapped ICD-10 diagnosis codes made for each patient in previous years that have not been used this year. And I found a high correlation between HCC Accurate EHR problem list and the annual use of the HCC codes. In other words, if it's in the problem list, mapped to the right HCC ICD-10 code, then it's more often than not included in a diagnosis sometime that year. If it never made it into the problem list, it's unlikely to be recoded. It's good if the analysis is done comparing last year to this year in your own practice group or organizations. It's even better to compare multiple years, looking for codes that have been diagnosed in multiple previous years. And it's best if your vendor has access to insurer source claims like Medicare's CCLF files that track patients across all providers in multiple years. And it's a great process as well when it's combined with update and clean up the HR problem list to help confirm that it's going to be used year over year. The second analysis I like is a near miss analysis, finding codes that have been used that are not HCC mapped but are similar to codes that are mapped to HCC codes. Combining that with a process that checks for eligibility for the HCC mappable code and updating as indicated the problem list can greatly improve things. And I've found some modest-sized organizations that can make millions of dollars worth of difference in their annual Medicare Advantage plan charges by being careful with their coding. And the risk adjustment that's done in value-based programs can be significant with care in this program. Thanks, Lori, for the great question. I hope this has been helpful, if maybe a little bit confusing.
That was definitely more of a question than I thought it was on first reading. Thank you for that, Dr. Mingle. Next up is Gretchen. Gretchen asks, in the process of sunsetting the web interface for MSSP ACOs, Medicare has cut the number of measures from 10 in the web interface to 3 by MIPS CQMs or ECQMs in the APP. Why the reduction in the number of required measures?
Good question, Gretchen. And I think there's 3 reasons. One, or Medicare has one existential requirement and it's 2 strategic commitments. The existential requirement is political expediency. They don't do well if they make everybody unhappy. So often Medicare will trade one painful policy for relief of some of the barriers. So I think that move from 10 to 3 measurements is a nod to that political expediency. But also, they have a commitment to what they call the Meaningful Measures Initiative to help move the system toward more meaningful measures and less just measurement for measurement's sake. And they also have a commitment to reducing the burden per providers. Now, that doesn't always work out because measurement of value adds some burden and is inescapably adds burden. But in these cases, focusing on 3 measures is good politically. Focusing on these 3 measures, no one can argue with the value of better control of diabetes, better control of high blood pressure, screening and treatment for depression. They're very important diagnoses, so fit the Meaningful Measures Initiative fairly well. And reducing to 3 does give a nod to the reducing burden goal. So I think we can expect some changes over the years in those measures. Whether they add more is uncertain. It wouldn't be surprising if they do, and certainly shifting to other measures at some time might also make some sense. So thanks, Gretchen. Good question.
Excellent. Thank you. And next, we have 3 questions from Karen. Her first question is, we recently joined an ACO. The ACO says it is interested in patients, not providers. Is an ACO participation arranged at the NPI level by having the NPIs on the participant or another list? Why the ACO focus on patients, not providers?
Karen, that's an interesting experience and an interesting question. Seems to me that the statement you attribute to your ACO is not a statement that maps to any common sense, but one that maps to a mission, vision, or marketing stance. It's market expedient to be patient centric. Everyone's talking about the patient centered medical care. From a common sense standpoint, the relationship that an ACO has with a patient is focused on the interest of providing the best possible health care at the best possible price, accessible to all. That's kind of a restatement of the triple aim, or the mission vision of the of consumers for affordable health care. An ACO has nothing if it has no providers, if it doesn't have NPIs to offer to the patients to help with their health care. So the statement interested in patients, not providers, implies a zero sum game. It's not a zero sum game. Both can be users. The best approach is to understand that a sustainable system of high value care that is high quality and affordable cost that pleases patients has to be provided by a set of providers that are satisfied professionally, financially, and personally. So I think you can be assured that in the background, the providers are going to be valued, or your ACO isn't going to survive. And you've all got to find a way to please the providers while you delight your patients. And that's the only sustainable system you will have. Thanks, Karen.
Karen's next question is: what are the implications to a practice when there are some providers reporting quality with the ACO and others that are MIPS participants?
Good question, Karen. Every APM has some kind of reporting requirement. It might be unique to the alternative payment model, APM, or piggyback on some other reporting program like MIPS. From the MIPS side, it's dependent on how you report. If you report as individuals, only the individuals needing a MIPS submission will submit MIPS, no duplication. Those who are qualified participants don't make a MIPS submission but submit with the ACO. But with the typical enormous advantages of group over individual submissions, it's more likely your MIPS participants will submit as a group. According to Medicare, group submissions should include all patients, all insurers, and all providers in the group. And the group is defined on a tax ID number basis, whether they are ACO participants or not. Under APP submission rules, once the ACO moves off of web interface to CQM reporting, either eCQMs or MIPS CQMs, it's also all patients, all payers, and all providers. I'd expect the whole data set for the tax ID number will be contributed to the ACO. Medicare has addressed the group submission issue. All providers are included in submission. MIPS and ACO providers, but I haven't read anything yet clarifying the ACO perspective. At the moment, I will be submitting all providers, all patients, all payers for the ACO side as well, until Medicare provides any other kind of guidance on that. This is a case where double dipping is permissible, in fact required from the MIPS side, and I think likely to be required when Medicare recognizes it as a whole from the ACO side.
Okay, the final question from Karen today is it a requirement that the EMR be certified to participate in an APM? Would we have to implement a patient portal?
Great question, Karen. Now, certified EHR is a requirement for all alternative payment models. I know from your other questions that you're joining a new MSSP, and I'm assuming it's a one-sided model, therefore a MIPS APM MSSP. The current requirement for the MSSP of any variety is that 75% of the participating providers are on certified EHR. So not exactly a requirement that you be on a certified EHR. There's that 25% fudge factor that if you're falling in that 25%, you don't have to have an EHR. That 25% allowance covers those people who are still on paper charts, or those who are using an EHR that's not certified, or you're on a previous version of a certified EHR that you've not yet upgraded to the new certification standards. Now, the patient portal issue is a little bit different. You're not required to have a patient portal if you're qualified participants in advanced APM. There's no patient portal requirement at all, though it's still a great idea. If you're a MIPS APM, your score for the promoting interoperability performance category will contribute to your global MIPS score. The patient portal counts for 40 points out of the possible 100 for the promoting interoperability category. So you can still be scored and you can still get a total MIPS score without a patient portal. There are 10 bonus points that you can use to offset some of the loss of 40 points for not having a portal. So your lack of a portal will calculate to an unavoidable 7.5 percentile points on your overall MIPS score. But again, you can make it up with your other scores if you got a great quality score, a cost score, and a practice improvement activity score. So you can still be in the incentive level for your total MIPS score, even without the patient portal.
Karen, Lori, and Gretchen, thank you too for the great questions. If you listeners have a question for Dr. Mingle, please leave it in the comments on LinkedIn or YouTube, or send us an email at hello@minglehealth.com. As always, Dr. Mingle, we have fun doing this. Thanks for sharing your insights with us today.
Thank you, and thanks for all the great questions. I want to be helpful, and I want that to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience, ask your questions. We can be smarter together.